some reason my mouse pad is very unresponsive when I turn on Zoom. Okay, so we are going to move on to Chapter 6. Chapter 6, the focus of Chapter 6 is looking at cost allocation. So we've been looking at variable cost and fixed cost as kind of two ways of looking at managing an organization and kind of starting to understand the underlying cost structure of an organization. Now we're going to do a slightly different perspective. We're going to talk about cost in a slightly different way. And we're going to start to think about organizations as having subordinate units, right? So, for example, back in the day, not that long ago, right, but before you were born, it was more common for physicians to be solo practitioners, meaning they were basically a sole, they hang out a shingle and they were their own business. So they were sole proprietorships. They maybe have some other technical form, but basically they were sole proprietorships, right? You know, one physician, family medicine guy, you know, or gal, hang out her shingle, his shingle, and be, you know, Dr. Alley, you know, and you'd go see Dr. Alley at her office. Over the last 30 to 40 years, there has been a progression of changes in cost, right? The fixed cost in particular of running a medical practice have risen. And so what we learned from Chapter 5 was high fixed costs require lots of volume to spread those costs out to make them smaller, right? So the only way you can do that is to take one physician, join up with another physician. So Dr. Alley and Dr. Samantha get together and they merge their businesses, and then they're able to share the fixed cost, right? So now they can, instead of Alley paying for an electronic medical record and Samantha paying for an electronic medical record, they get together and they form a group practice. Now maybe it's just two people, right? But they can buy one electronic medical record and share it. So the electronic medical record is a great example of a fixed cost. There are some variable costs in there, but mostly it's the setting up of the system that's very, very expensive, right? And so they get together and they can share that cost. They can also share things like they can share the same front desk people, right? So they can share the same office manager. They can share the same billing clerk, you know, and so they can spread those fixed costs over a larger volume, which makes those fixed costs go down, right? And so that was the incentive. That was one of the major incentives of this consolidation that we've seen of physicians forming into groups. There are some other factors involved there, like the smaller you are, you've got the small physician practice, single provider, and the big insurance company that comes in and starts muscling the, you know, and saying, well, you know, if Allie and Sam are both physicians in the same community, then they, you know, the insurance practice can play one against the other, say, hey, Allie, Sam said that she charges, you know, $75 per visit. How much you do? And then Allie's like, I'll do 70. And then they go back to Sam and they're like, hey, Sam, Allie said she'd charge 70. How much you go down to? And Sam says 65. And then back and forth until they bid down to, you know, I can't, you know, uncle, I have to charge at least $55 per visit, right? And then they're like, why am I in this business at all? Why did I go to 10 years of schooling? You know, I'm making the same as, you know, my front desk clerk at the end of the day. So they started getting together and forming bigger practices so that there were fewer organizations for the insurance companies to play off each other. So that's kind of the other piece of that. What we're going to focus on today, though, is the first part that I described, which is we get, as these organizations kind of became larger and more complex, and maybe it wasn't, you know, Allie and Sam, both family medicine docs, it becomes, you know, Allie and Sam, who are a family medicine doc, and Emma, who is you know, a orthopedist, right? And Caitlin, who is a GYN, right? And they start a group practice, multi-specialty group practice. And now you've got, you know, same building, so they're sharing the same space. They might be sharing the same front desk people, maybe not, depending on, you know, but they're sharing the same medical record, which again is a really big expense. They're all sharing these expenses, but they've got now say 3 different clinics that may be, nominally, there are 3 different clinics, 3 different kind of operations that are happening in the same building, sharing the same front desk. So you come in to check in, and you might be coming to check in to get your family medicine. You might be coming to check in to get your orthopedics. You might be coming in to get your OBGYN, depending on who you, but you're coming into the same building. So they're sharing the same building, right? They're sharing maybe the same front desk. They're sharing the same IT structure, right? They don't hire 3 different IT guys to, come fix their computer. They hire one and then they share it. So the question that we're going to address in chapter 6 is, how do we spread those costs fairly, right, across the different practices? Because maybe they're using those shared assets at different rates, right? So maybe there's shared nursing staff, for example, and the family medicine docs need a lot more nursing staff because they're cranking out more visits than either of the other 2 practices maybe have longer visits, so they don't need as much nursing support. You could think about there are different drivers there. So maybe, family medicine does a lot more visits, so maybe they need more billing. They use more of the billing support, because the difference to a biller between writing a bill for $75 and writing a bill for $500 is, just a matter of writing a different number in, but it's really the volume of bills that the biller is generating that takes their time, not so much, right, the dollar value of the bills. And so we're going to look for different drivers, what we call drivers. These are the things that make those expenses go up. And so maybe if we're going to look, so let's say they have one shared billing operation for that combined practice. Family medicine generates twice as many bills as the other 2 doctors do, right? Well, who should pay, let's say family medicine, so let's say there's 4 of them in the office, right? Should the family and maybe the family medicine practice generates 60% of the bills that go out of that office, even though maybe they only generate 20% of the revenue, which is a common kind of trade-off there, right? So how should we divide up the cost of the billing operation? Well, if we're trying to figure out how much does it cost us to do a family medicine visit, we're going to have to allocate more billing cost, more of the cost of generating those bills to the family medicine visits than we are to the OB visits or the ortho visits. And so we're going to have all these different costs that are shared, right? Once we kind of collect up into a group practice, we're going to have to figure out, how do we allocate the different assets that are shared between the organizations, between the subordinate units within the larger organization, right? So for example, when it was fairly common in the military for us to put together in the same physical space our audiology practices, right? So these are audiologists, it's not a physician, it's a technical, it's a master's level. They do, they do the testing, they do your hearing tests, or if you've ever gone in the box and they put the headphones on and they play these really, really quiet beeps that and eventually you're like, I think that might have been a beep, and you're pushing the button and it says, stop pushing the button, there's no beep, Am I the only one that does that? All right. So, so I get paranoid because I'm not hearing, I'm thinking I should be hearing a beep. Maybe that was a beep. Start hallucinating beeps. But anyway, so we would very often put audiology and ENT together, so ear, nose, and throat, because they have some related things. Like very often the ENT refers to, there's a lot of back and forth referral between those 2. So we very often would put the 2 together in the same kind of space. They would share the same front desk staff, for example, right? But this is a good example of where the audiology is a very high volume, low price, right? It's a relatively low cost service, but it's a high volume. ENT is a surgeon, they're surgeons, right? So they're going to see a lower volume, but a higher price point per visit, just kind of on average, right? Relatively speaking, on average. Your ENTs are going to see fewer visits, but higher price, higher revenue per visit versus your. But we put the 2 together because they're related, and that's just a thing that we did in military facilities, and it works, right? Ophthalmology and optometry, right? The 2 different services, both doctors, but the ophthalmologist is a surgeon, right? And is going to do things like if you have cataracts or, problems with your retina, or, you're going to go see the ophthalmologist. If you need glasses, you're going to see the optometrist. So right, but the two are both working on eyes. So very often we put them kind of together because they're doing a lot of cross referral, right? So they sometimes even share some of the same support staff. Right? We need a optometry tech can do a lot with the can help the ophthalmologist with a lot of things because, so we might have not only might you have shared space, shared front desk, shared scheduling system, shared administrative support, but you might also share some of the same tech support. Okay, so we have these two practices in the same physical space. They're sharing that, So the question becomes, how do we share out when we're trying to determine how much does it cost for an optometry visit versus an ophthalmology visit? So we've got to be able to figure that out when they've got these shared assets. And it's not going to be, I will tell you, it is very often somewhat difficult to kind of sort that out. And so we have to come up with a methodology. Now, there are some examples, and I'm not just rambling here, this is all relevant, right? So let's use the ophthalmology and optometry example. Okay, so let's say optometry has a dedicated optometry technician, and all they do is optometry, right? And then the ophthalmology office has a dedicated nurse, right? Who does, because it's this is more complex, more, you're actually dealing with medical issues that, potentially have, she's dealing with wound care and things like that, right? So it's more complex. So they have a dedicated nurse. The nurse never crosses over to the optometry. The optometry tech never crosses over to the ophthalmology. The nurse and the optometry tech would be examples of what we call direct costs. Okay, so there's this idea of a direct cost. That means that the cost is budgeted and expensed only to the specific areas that they support if they never cross over, right? So there would be a direct cost. The nurse would be a direct cost to ophthalmology, as would the ophthalmologist, as maybe that's kind of obvious, but the ophthalmologist's salary would be a direct cost to ophthalmology. The optometrist salary would be a direct cost to the optometry service. The optometry tech, if she never crosses over into the ophthalmology, would be a pure direct cost to the, excuse me, to the, I said optometry, yeah, the optometry tech would be a pure direct cost to the optometry service. So we're going to distinguish between direct costs in this case, right? Which can be, by the way, here's where it gets tricky, can be variable or can be fixed, right? But we're having like a different category, category of costs. So we have direct costs. These are the costs that are exclusive to a particular service, right? And then we have what we're going to call overhead costs, or indirect costs. You can use either one of those, overhead or indirect costs. These are the shared costs, okay? So using our ophthalmology example, we have direct costs to ophthalmology of the ophthalmologist's salary, assuming that this is an employed physician, the ophthalmologist's salary, and the ophthalmology nurse, right? And so those two are direct costs to ophthalmology. We have the optometry, the optometrist, and the optometry tech. Those are direct costs to the optometry service, right? So we've got those two separate services going, but they share the same space. So now we're sharing a space between they're in the same. They share, let's say, the same waiting room. So all their patients come into the same waiting room, and they get seen and they get checked in by the same front desk staff. So maybe Taylor is working at the front desk, and she's checking in Caitlin, who's coming in for her eye exam, right? And you guys don't have your cards up, so I can't pick on you except for Sam. But so Caitlin and Sam come in, right? Or Chloe, right? They all come in for their visits, and maybe Caitlin's coming in for ophthalmology, Sam's coming in for optometry, right? But Taylor Taylor checks them into their appropriate services, but they're all coming to see Taylor. So Taylor is a shared asset between the two services. She is an overhead cost. So Taylor would be an overhead cost. The cost of the shared waiting room would be an overhead cost, right? We've got to rent that space. Even if we own it, it's the shared depreciation is the other way we look at it. Depreciation, we kind of treat depreciation like rent. It's nominal, but it is a real cost. So we've got to figure out a system of how do we share out Taylor's salary between the two services. Right? So that's an example of an overhead. Okay. So that's what we're going to talk about in this chapter. Yeah. Right. So Emma's asking, you know, if we are going to, would the building be a direct cost or an indirect cost? So presumably you have, let's say there's a, we're talking about a group practice with multi-specialty group practice, and they own a medical office building, an MOB. You can hear that acronym, MOB. They own an MOB. The practice, the group practice owns the MOB, right? And then they allocate if they own it, or let's say they rent it, just to make it simpler, right? So let's say they rent it, and then they've got all these different services kind of spread out through the building. They would allocate, because the rent is paid by the organization, they would come up with a mechanism for allocating the rent to the subordinate organizations, to each of the services. So the driver would be probably the driver, and we're going to talk about this idea of a cost driver. The driver would be fixed. It wouldn't change, and it would probably be square footage, right? That would be, so we've got this rent. We've got a 10,000 square foot building, and optometry uses 2,000 square feet of it. They would basically get 20% of the monthly rent bill allocated to them. So the rent would be paid at the organization level. So that's a good way to think about it, if a thing is overhead, it's paid at the organization level, and then it's shared down to the subordinate sections. And it wouldn't change all that much, right? This would be a thing like, okay, you know, you're occupying 2,000 square feet. It's not going to change on a day-to-day basis, right? Ophthalmology is not going to move in and take 500 square feet, then move out the next day. And, you know, it's going to be pretty fixed. So it doesn't, so the ratio of sharing, it's still a ratio operation. Right. Well, so the overall is got to, ultimately everything funnels back, you know, funnels up to the overall practice. But what we're trying to figure out is how much do we have to charge for an optometry visit so that the optometry is covering its costs. Right. So Emma's asking, it doesn't matter what revenue they're bringing in, right? So revenue is a different perspective. What we're really interested in in this chapter is its costs. And so Emma was giving the example of orthopedics versus pediatrics. That's actually a great example, right? Because orthopedics is always a moneymaker, right? They make huge money, and as do most of the surgical services. As opposed to primary care, very often is a loss leader, right? So multi-specialty groups will hire primary care providers and have them in the organization to drive traffic to the specialists. So very often, primary care doesn't earn enough revenue by itself to pay its own bills, right? So is that what you're kind of getting at? Yeah. So I mean, it's okay. We just need to know, right, from a planning perspective, how that's working. So it might work out that, you know, it costs us $75 to generate a primary care visit, and we only get $60 in revenue, let's say. So we might lose money on every visit on average from our primary care. Exactly. So for every kid. So if it's pediatrics, right? Every time some kid jumps off the back of the sofa and bangs their knee up and mom gets scared, they come and see the pediatrician. So, well, I'm just a pediatrician. Let me refer you over to the orthopedist. He'll have a look at the knee and do all this other fancy stuff, right? Or, you know, mom comes in and says, kid keeps getting ear infections. All right, let me refer you to my colleague on the third floor in the ENT department so she can evaluate whether your kid needs tubes or not, right? So very often a multi-specialty practice employs its own primary care as a means of funneling business to the other specialists who really kind of are the money makers for the organization. Make sense? We still want to know how much does that cost, right? So that we can, because if we can identify costs, we can control them. If we have no idea what our practices cost, even if they lose money, we want to know, even if we know that they're going to lose money, we still want to look at how much are they, you know, how much does it cost, so we can figure out, all right, is there a way that we can reduce their costs and make it less expensive, right? So that's kind of where we're going. All right, so let me switch my view. There we go. Okay. So what we're going to be talking about is called cost allocation, right? And there are the costs that we're dealing with we're going to frame costs in this chapter as direct or overhead / indirect. You can use either of those phrases. You will hear them used interchangeably. They mean the same thing, you know, within this framework. So the idea here is that we have these organization level costs, and we need to figure out a way to share them out. So let's talk about direct costs a little more to clarify, right? These are associated only with a subunit. And the key, when you ask yourself, is this a direct cost or is this overhead? One way to kind of diagnose that is, if the subunit went away, would the cost also go away? Right, so one way to kind of discern between an overhead or indirect cost and a direct cost is to look at the cost and say to yourself, okay, if we stop seeing pediatric patients, would this cost go away? Well, what cost would go away if it's for pediatric patients? I mean, there's pretty generic stuff, but you know, maybe you wouldn't be buying any more lollipops for the practice. So that's a you know, being a little, or yeah, go ahead. Playroom in the well. So let me come back to that one. Maybe pediatric size equipment, like pediatric size, I'm trying to think, blood pressure cuffs, right? So if we don't have pediatric visits, would we have pediatric blood pressure cuffs? The answer is no, we wouldn't have them anymore, right? So pediatric blood pressure cuffs would be a pretty good example of a direct cost for pediatrics. If we were talking about, we used a lab example a lot in the last chapter. So if our group practice had its own laboratory, right, and some of the direct costs of the lab might include things like reagents. Those are the chemicals that they use to process your tests. Rental of equipment, of testing equipment. That's an example, you know, of a thing used in the laboratory. If the laboratory went away, would the organization still have reagents as a cost? No, because they would show, you wouldn't have any equipment, you wouldn't have somebody to run a test. So you wouldn't have reagents. So that cost would go away. If the lab went away, the cost of the testing machines would go away. The cost of the reagents would go away. So those are examples of direct costs. And but going back to the pediatric example, and Emma said the waiting room, right? Well, the waiting room is a space. So if pediatrics folded up and we're like, yeah, we're not doing pediatrics anymore. We always lose money on pediatrics. I'm not going to do that anymore. Would the cost of the waiting room, of the pediatrics waiting room, go away? No, right? Because you're renting, you as the medical organ, or the group practice are renting that 10,000 square foot medical office building, and the landlord doesn't care if you don't have a pediatrics practice in that space or not. They're still like, give me my $200,000 a month or whatever it is that I'm charging you for the space. I don't care. Whatever you do with that space, turn it into a broom closet. I don't care. I still want my money, right? So that's an example. So space is often an example. Space is pretty much always an overhead cost, because if you take away the operation that's operating in it, the space cost is still there, and it just has to be redistributed, right, if you don't do anything in that space, if it just sits there empty, you're not utilizing space that you're paying for. And so that rent bill has to still be spread over fewer practices. That's all that happens. It just makes the rent more expensive for all the other practices. So you actually make sense. Hey, like, if we're not going to have pediatrics, we got to put something in there so that we can, utilize that space rather than have it sit empty and we pay for it, right? Which is a thing we'll come talk about a little more. So this issue of, so this is a good way to kind of test whether a thing is a overhead cost or a direct cost. Is if I stop doing the service that this cost is associated with, would the cost go away? And so the answer typically for things like supplies, for things like personnel who are clearly connected to the practice, those are typically direct costs. Those are good examples of direct costs, right? So supplies that are specific to the service probably will go away if you take away the service, right? Personnel who are specific to the service. So if it's a laboratory, if we get rid of the laboratory, what happens to lab tech salaries? They go away, right? Because we're not going to use the lab tech in the pediatrics department. So those are good examples of ways of thinking about direct costs and trying to identify a direct cost. Okay. Then we have overhead or indirect costs. Right, and these are these subunits use services or resources shared across the organization. So these are incurred, these costs are incurred by what we're going to refer to as a cost center. But they are used by subordinate units. So examples of shared costs include things like building, parking, right, other real estate kind of things, housekeeping. So going to our group practice, right? If the group practice rents one big 10,000 square foot MOB, each department or service isn't going to have its own housekeeping contract. It's going to the practice is going to contract for housekeeping services as a practice, and then it's going to send it, and then it's going to, there'll be a housekeeping manager that manages the services across the whole organization. So there's typically a centralized housekeeping service or cost center. Yes, ma'am. So the question was, can you drill down into housekeeping so that you look at the cost of supplies? So the answer is no, typically not. It's possible, right? Like it could be possible to do that, to drill down and be like, okay, this quart of Pine Sol is being used in pediatrics and this quart is being used in. So if you had a rehab pool and you had pool cleaner, yeah, that would probably be a direct cost. Like that's clearly, or so it'd probably be ordered by the organization. So it could go either way, right? Yeah, typically you're looking at it as an overhead share. But if you had a very specific thing that you needed to buy to take care, so if you had a rehab pool for PT, right, that would be. You could conceivably have PT ordering those supplies, and then housekeeping or maintenance would just show up and use them. But typically, if you're talking about generic housekeeping, cleaners and things like that, this is where we get into, is the juice worth the squeeze, right? Is it worth the effort to figure out, how many quarts of Pine Sol were used in this service as opposed to that service? Or do we just do some sort of allocation method, which is what we're going to do in this chapter, that just kind of says, all right, this many square feet, on average, we're going to use about this much supply cost, and this, so what we can then just do is aggregate it all up into housekeeping cost and just allocate it back out that way, right? But if you had, I think a good example, like if you had something very specific, right, you could say, all right, department, that owns the pool, you have to order the supplies to maintain the pool as part of your budget. That would actually make sense, and it'd be relatively straightforward. It's just a lot more complicated if we get into like, who's going to order the wax this week, that kind of thing. So housekeeping, very often utilities, it's hard to sort out, it's hard to sort out. Is ENT really using more electricity than pediatrics, right? We conceivably, you could put a, what do they call the gauge that sits on the side of your house? I'm blanking on the name. But what I'm saying, like on the side of your house, if you're like running your air conditioner and all kinds of different things, if you go outside and you look at the gauge on your side of your house, that wheel starts spinning really fast, indicating you're using a whole lot of electricity, right? So you could conceivably put a monitoring device in each service that would give you an exact amount of utilities costs for each service. But again, that's costly to do, right? You'd have to rewire the building so that, and that's costly to do. So it comes back to that, is the juice worth the squeeze kind of thing? You're going to do a cost benefit analysis there and say, probably not. It's probably better to just divide it up, find some reasonable mechanism to divide up this aggregated cost and then share it out. Very often, a big area that that group practices save on is consolidated billing, finance, HR, right? There's no need to have, particularly back office kind of stuff gets consolidated. So Wentworth Douglas, for example, just became part of, not just, but recently became part of Partners. Well, or what is it? Mass Gen Brigham now, whatever they don't want to be called. It's MGB. They don't want to be called MGB, but we're going to call them MGB. So the MGB system, right? And one of the things that the MGB system does to reduce costs is it consolidates billing and all the back office portions of billing and finance. There's some big building in Waltham someplace, probably, I'm making up, it's somewhere down in the general Boston area, probably not downtown Boston because that's expensive, so they throw it out somewhere in the suburbs, right, where there's a big cube farm of people processing bills for the entire MGB system that might include Mass Gen, Boston Children's, right, Newton Wellesley, right? All the hospitals that are part of that, nobody's there, because back when those organizations were separate entities, they had a billing office for each of their buildings. But once they consolidated up into MGB, right, MGB just kind of sweeps all those functions up into one big office building where everything is being done there, right? So, and the same thing with HR. A lot of HR functions don't, it's things like processing payroll, right? I don't need to have my payroll processed in the building where my employees are, right? I can, if I'm part of a big system, I can have a centralized HR office that handles all the things like, initial screening of resumes, payroll, and all those other kinds of things. So that's again an example of right, fixed costs, right? Well, overhead costs that can be consolidated down. So, for example, LRG Healthcare, the Lakes Region Hospital System, is in the process of declaring bankruptcy. They're going to get acquired by Concord Hospital, most likely. That's kind of everybody's expecting that to happen. Everybody's been expecting that to happen for years. When that happens, they don't need two CFOs, right? So they will fire the CFO for LRG, most likely, right? And they will fire some portion of the finance staff for LRG. And then all of the finance work will be done out of Concord's finance shop. They might have to beef up Concord's finance shop a little bit, but they will probably be able to get rid of more finance staff than they have to beef up, right? They'll probably be able to fire most of LRG's finance staff and take a little bit of what's left over to Concord in order to kind of increase their capacity. And they will get economies of scale from doing that. Same thing with HR, right? So very often when we see these consolidations, that's what happens. And it happens because LRG by itself can't sustain all the fixed costs that it has to incur. IT is another great example, right? Very expensive. So LRG can get on the same IT contract as, or EHR contract as Concord is, and then they can spread that, instead of each of them having an EHR, they can share one, right? So instead of paying for two EHRs, now they pay for maybe the equivalent of 1.25 EHRs, right? So they have a significant cost savings. And those EHRs are no joke, they're millions of dollars, right, in costs. So it's typical to have things like that shared. Security is another example, right? So you have a security person or team that kind of takes care of the building as a whole. Which practice should pay for security? Well, they all have to pay for security because it's kind of this, it's not clear who's getting the direct benefits of security, but they're all as a group, you still want to have it. So we've got all these things. It's convenient for us to have these things. The clock is actually accurate. Somebody fixed it. Usually, it's like 8 minutes slow or something, and then I'm always talking when the other class is waiting outside. So it's convenient, right? We can get economies of scale by bringing together related functions into one organization. So we can get economies of scale by bringing together different practices, different specialties, right? And maybe even bringing them into the same building, but now but they're sharing, they've got one big building, right, with shared parking and shared housekeeping and all these things, shared security. So maybe they were able to get rid of and shed some of their billing staff, some of their finance staff. They were able to have fewer security guards per square foot or per person in the organization. But now they still have to figure out, now that they're not paying for it by themselves, right? Because back when, Allie had her own practice, she knew exactly how much her IT cost because she paid it directly, But now that she's part of you know, of the group practice, right, she doesn't really know how much she pays for IT. But hopefully it's less than when she was by herself. Otherwise, there would be no point. Okay, so now the question becomes, we've got all this great stuff that we're hopefully, we've consolidated, and we're hoping to have, get economies of scale from. How do we go about sharing, figuring out what a fair share is to each subunit? So this is the cost allocation question. Right, so this is again what we're talking about. This is a it's a pricing process used to allocate costs from a supporting department which we're going to call a cost center, to a supported department, which we're going to call a profit center. Okay. So a cost center generates only cost. Only costs. That doesn't mean it doesn't generate value in the sense that this is something that the organization values, but it's a cost center because it only generates cost. Right? In other words, no revenue. Examples: HR, IT, housekeeping, right? All the things we just had on our list a minute ago, right? Finance. Finance may send out the bills, but it doesn't generate anything that anybody wants to pay for, right? But an organization needs all these functions in order to function, right? It needs all these services in order to function. You can't have an organization without HR. You can't have a functioning practice without somebody doing finance. You can't have a functioning modern healthcare organization without IT. You can't do these things. I had a back when I was very young, not much older than you, I was a medical platoon leader in a cavalry squadron, so the tank unit. And I was part of the support, what we call the support troops. So you had the squadron, big squadron, you know, and there was divided up into troops. And 4 of the troops were guys that drove around in tanks. One of them was an artillery troop, big guns. And then there was the support troop, which had things like the mechanics, because tanks break down all the time. The fuelers, because tanks drink fuel, they get 1 mile for every 2 gallons of jet fuel. They run on jet fuel. Cooks, right? Food, because when you have a couple of thousand people out in the field, you have to feed them. And the medics, which is what I was in charge of, right? So you had support troop, right? And support troop is kind of like a cost center to the organization, right? Support troop doesn't go out and kill bad guys, right? It's the tanks that go out and kill the bad guys. So they're kind of like our profit centers, right? And so we would often, the tankers would give us a bit of crap, about like, you're not a real soldier, blah, 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 right? And that's just how it is. And my commander at the time was the commander of the support troop, put a plaque over the entryway to our headquarters, and it said, "Try fighting without us," right? Which I think is just a marvelous, it was a great morale kind of booster, because it's like, how far do you think you're going to go, tanker, without the fuelers following behind you? Well, you got like a 100-gallon tank, and you get 1 mile for every 2 gallons, so you can go about 50 miles, and then your big hunk of metal stops moving. right? So try fighting the bad guys without fuelers coming behind you, right? How long do you think you're going to sit in the field and not eat? Good luck with that, right? You can last a couple of days. So that's kind of, so the idea that I just love that phrase, try fighting without, is take that to the same idea of, support services within a healthcare organization is the same thing. It's not fighting, but try providing healthcare without the finance team. Well, you can do it for a couple of days, and then you run out of money, right? You can run an organization without HR till the end of the week when all your employees don't get paid, and then they say, yeah, we're not coming back, right? So, very often you as future healthcare administrators will be like, you don't really contribute anything to this organization. Well, yeah, I kind of do, right? Try fighting without me, right? Try running this organization for any period of time without me, right? And you'll find out what I contribute. So, that may be a little bit of that might be a little bit of me working out some of my angst about mine, but you will feel it soon enough, right? But the point is, these functions don't bring in revenue, right? They are essential functions, but they don't bring in revenue. So they're called cost centers. The services that see patients in a healthcare organization, that's where we make the money, right? Those are the services that actually make the money for the organization. They bring in both, so these profit centers bring in both revenue and cost, right? So your ENT service, your ENT surgeon, sticks a scope up somebody's nose to look to see if they've got a deviated septum or something. That bills out it for $200. That's revenue coming into the organization. Somebody has to pay for the scope. Somebody has to pay for the tech that prepped this patient. Somebody has to pay for the anesthetic that they spray up your nose before they shove the scope up there, right? All that, those are costs. So ENT has both revenue and cost. So it is a profit center, as opposed to these organizations are pure cost. There is no revenue coming in for them. So that's when we use the phrase profit center and cost center, what we're referring to are organizations within our organizational units within our larger organization that on the one hand, cost centers just generate cost. On the other hand, profit centers generate both revenue and cost. And so to know how profitable the profit center is, right, we need to know what their total cost is. So they're going to have revenues, they're going to have direct costs, right? And then they're going to have overhead costs. So the revenues are whatever they generate, right? That's the money coming in, right? Then they have direct costs. The direct costs are going to be things like supplies that can be clearly connected to the practice, right? So that's we talked about the lab. That's going to be the reagents, right? They're going to have some personnel that are clearly connected to the practice, right? But then they're going to have overhead. They're not going to have, if you're a dermatology practice within a larger group practice, you're not going to have your own HR. You're not going to have your own IT. You're not going to have your own, yada, 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 right? And so this is all the support that you get. So this is your HR, your finance, right? And so on, right? You're going to get a share of that allocated, right, to a particular practice. And then that tells you the profit, right, of the organization. So if you were to look at dermatology practice that's part of a larger group practice, and you only looked at their revenues and their direct costs, they might look really, they would look really profitable. But the reality is they're not you're not capturing the full cost of running that organization. In order to capture the full cost of running that organization, you've got to look at all of the supporting costs that are not being captured by the direct costs, right? So a lot of times, primary care practice might look profitable, if you look at strictly the revenues that they bring in and then their direct costs. But and so they'd be like, oh, you know, I brought in this much money. I paid my providers, I paid my nurses, and look, we have all this money left over. And wait, that's not all of your costs, right? If you were in private practice as a sole practitioner over here, you know, by yourself, you would have to pay, you know, you would bring in your revenues. Yes, you'd have to pay your L&A and, you know, and whoever else, but you would also have to pay your front desk staff. You would also have to pay rent on your building. You would also have to pay for IT support, right? All those things we, the organization, are giving you, right? Because you're now part of our macro organization, our big organization. So you have to pay out of your revenues. You have to help us pay for those overhead costs. Right? And so that's when a lot of times these less profitable services suddenly turn negative. It's not when you just compare their direct costs to their revenues. It's when you say, well, okay, but we also have to allocate your share of the rent, right? And then they turn negative. That doesn't mean that they're not important, right? Again, you know, try running a medical system without primary care. Good luck. You know, you're not going to get the referrals that you need. All right. So we're going to finally get to this allocation process. The cost allocation process is a 4-step process. You're going to need to memorize these 4 steps. Okay? Step 1 is to identify the cost pool. What is the cost pool? What do I mean by the cost pool? Well, housekeeping, so we've been talking about housekeeping, right? Housekeeping cost pool is going to include, well, let me ask you, what are the costs that are going to be included in running housekeeping? We have a 10,000 square foot medical office building, MOB, right? And we've got to have a centralized, someone in the basement somewhere is going to be the housekeeping, you know, operation. And they, you know, kind of emerge at night to do a deep cleaning of the organization, right? And they, you know, make rounds during the day to empty the trash and things like that. So what are going to be the costs associated with running housekeeping for a big building like that? What do you have? Waste removal? Okay, so you're going to have to pay a trash company to come pick up your trash. And waste removal, by the way, when you're in healthcare, there's all kinds of different kinds of waste, right? So I used to bring a facilities guy in when I taught management, and he would talk about, yeah, we've got the regular trash. Then we've got, but you have to divide your regular trash into recycling and non-recycling, right? You're a medical operation, so you have patient protected information. So anything that has a patient identifiable information on it, that paper can't go into regular trash because you'll get fined, right? So that has to go into like a confidential disposal. So there's that kind of trash, right? You have, you have a cafeteria, so there's food waste. That's a different kind of trash, right? And then, oh, by the way, you have medical waste, right? And you have, and oh, by the way, you might have radiological waste. And it's like, so it's like, it sounds simple, right? But it's actually really complicated, right? So it's, so we've got, all this kind of waste removal, right? That's, okay, what else? Cleaning supplies, sure. So he's got to use lots of supplies, right? So you're going to have, anything that's, so we put in the supply category, anything that's going to be used up within a year, right? So you're going to have expenses. So that's going to be your Lysol and your Pine Sol and your wipes, right? We've got, and your hand sanitizer and, and your soap and your, wax and, yada, yada, yada. So you're going to have all those supplies. What else? Wages, so manpower costs, right? Wages. It's a manpower intensive operation. You're going to have a lot of people. This is one of those arguments, like when we start to look at how do we share out the HR, HR costs, right? Well, housekeeping employs a lot of people, but they're all relatively low wage, right? As opposed to, you know, Department of Surgery, if you have employed surgeons, right? Relatively few number of people with really high wages. How do we divide out HR costs? Should we divide it out based on headcount, or should we divide it out based on salaries? Because chances are the total salaries in surgery are like 3 times what they are in housekeeping, right? But there's a lot more housekeepers. So, you know, so this is the question. We'll come back to that in a little bit. But this is the questions that we're going to start asking ourselves when we get a little further down. So, housekeeping pool, right, is a pool, right? Your pool meaning you're dumping everything together into one pot or pool, right? Are all of the direct costs for the cost center. Okay. So all the direct costs, all the things that are paid for by housekeeping, and that would include wages, supplies, equipment too, right? So, any of you guys ever worked as a housekeeper? No? Good times. You know, I learned how in the Army. I wasn't a housekeeper, but like when I went through basic training, you know, we had to learn how to run the buffers and things. So this big buffer. The thing will take off on you too if you don't know what you're doing. It'll go spin you around. Anyway, so you know, it's good development. Everybody should spend some time cleaning bathrooms, and it gives you a little bit of humility. So you identify the cost pools, right? You have direct costs of the cost center. So all of the costs, all the budgeted costs that go into housekeeping become the cost pool for housekeeping. If this was IT, you'd have the wages of all your technicians, right? You would have probably stick into IT cost pool. You would have the Office 365 cost for the organization, right? They would have one contract with Microsoft to get, you know, the 100 workstations paid for, right? And it would all be in IT. It would be the contract with the EHR contractor would be in the IT cost pool. So it's everything, you know, the cost of running the website for the organization would be in the IT cost pool. So all of that would go into, so an IT cost pool. It was HR, you would have, you know, your recruiters, you would have your employee relations people, you would have your compensation specialists, you know, depending on how big your organization is and how specialized your HR. You'd have the people and the systems, people and systems that are running, that are doing things like payroll, right? So you have all these things. Okay, so step one is we've got to identify this cost, right? So whether it's housekeeping or IT or finance, we've got to identify all of the direct costs that go into supporting this, you know, to running that operation. So that's step one. Step two, identify the cost driver. Okay, so this goes to what I've been saying kind of as we've been moving along. So HR, right? The example we were using a minute ago with HR. What we've got, so we've got the cost of recruiting, we've got the cost of running payroll, we've got the cost of employee relations. So every time an employee does something naughty, HR gets involved, right? Manager calls HR and says, hey, you know, I caught Caitlin, you know, sleeping on the job again. You know, we're gonna have to do some discipline. So HR does all the paperwork, right? And then we, you know, give Caitlin a warning, you know. And so we've got HR. So the question is, let's say HR costs us $1 million. How are we going to allocate? And let's say we've got 10 services. How do we allocate? How do we want to allocate the $1 million? Well, the thing we want to ask ourselves is, what drives HR's cost? What is it that makes us generate that $1 million in cost? That if it went down, the $1 million would go down. And if it went up, the $1 million would go up. So what is the thing in our organization? And you could pick multiple things. We're going to typically pick just one, right? But what we can recognize is, even though we're going to pick one, we're going to hopefully pick the best one. There might be a second and a third and a fourth, maybe even choice. So what would be, how would you allocate, you know, let's say there are 10 services, let's say there's 150 people, and payroll is $20 million. I'm just making up numbers, you know, so we can talk. What do you think drives HR costs? In the sense that if something increased. So maybe if we got more people, would that make HR costs go up? If we had more divisions or services, would that make HR costs go up? If we had more payroll, would that make HR costs go up? Sorry? You'd say people? You'd say payroll, did you say? Payroll, okay. So the answer is yes, right? They all would make costs go up. And then the question becomes what? Sorry? Services. So when I was using services, I meant right. Okay. So yeah. So I meant, when I say services, I meant like a line of service, like we're going to add dermatology. We didn't have dermatology before we had dermatology. You know, and there are other, and you could, so rather than, I probably shouldn't use services, maybe I say clinics instead. Because you could also add services, HR services, right? So you could have a more robust HR program. Maybe you add, maybe you have something called an employee assistance program, which is like, you know, as it turns out, Caitlin, the reason Caitlin can't stay awake in the office is because she's addicted to, you know, pain medication or something like that. And so we have this employee assistance program that we refer Caitlin to and say, hey, Caitlin, go, you know, they're going to help you figure out what you need to do to get yourself straightened out. So those are, you know, different ways of different drivers, potential drivers. So one way we could say this is, look, there's 10 clinics in our practice. We just carve it up, divide by 10, everybody gets 1/10 of the cost. That's really simple, right? So this is the benefit of that is it's really simple. It doesn't change very often, right? Once we know it, we just say, okay, we're just going to divide by 10 and everybody gets a share. So would that be fair, right? So if we figure, so like family practice maybe has 5 or 10 providers with a bunch of, you know, LNAs and nurses, so they're very manpower intensive. And maybe, you know, our ENT practice is 2 ENT docs with, you know, with 2 technicians. Optometry, you know, maybe has you know, a couple of optometrists and a couple of, you know, maybe more manpower. Ophthalmology, you know, maybe there's 10 people in optometry and 3 people in ophthalmology. So we're going to carve up and give $100,000 to optometry in HR costs and $100,000 in HR costs to ophthalmology. What do you think the director of ophthalmology is going to say when he finds out that the director of optometry is getting the same bill? It's going to be a bit of equality and equity, but why? So why are they going to say, hey, that's not fair? Okay, so Caitlin said, yeah, so for people in Zoom, Caitlin said, you know, because ophthalmology has 3 people and optometry has 10 people. So your assumption is basically that the main driver here is the number of people then, right? That's what you're saying is well, maybe not the main driver, but you're saying that's a point of differentiation here, right? And I would agree, right? So that's a problem, right? But let's say ophthalmology, because the ophthalmologist is really highly paid, the ophthalmology payroll is really high, right? Whereas the optometrist makes, maybe the optometrist makes $150,000 a year and the ophthalmologist makes 500, right? And the optometry techs make, maybe 50,000 a year, and the ophthalmology technician makes $100,000 a year. Could it be payroll? Maybe it ought to be payroll, and let me make a case for that. The reason it ought to be payroll is because it's harder to recruit those people, and so HR spends a lot of effort to keep them, to hire them and keep them happy. Whereas if we're talking about family, jump over to family medicine, right? Family medicine has a bunch of LNAs running around. Those folks, maybe I think some of you are LNAs. You probably make $12 or $13 an hour, and no offense, but you're a dime a dozen. It's easy to replace you, right? Relatively speaking, because there's always somebody else behind you that's willing to take the $13. That's part of why an LNA doesn't get paid that much, is because there's a lot of people that could easily become an LNA. Not so easy to become an ophthalmologist or even an ophthalmology technician. It takes some schooling, it takes some time, it takes some effort. Whereas becoming an LNA requires a few weeks of OJT, right, on the job training. And then you take a little test and you're good to go. So one argument could be, payroll actually, even though payroll is distorted by the high wages, those high earners require a lot more effort on the part of HR. So kind of the point here is there's a lot of good answers and you've got to pick one, right? If we're going to choose one. Now it's possible to be more complicated and pick multiple ones and have a multiple input system. We're not going to do that. We're just going to pick one. So let's say that we pick people, right? So rather than salami slicing it and saying, all right, well, there's 10 services, so each of you get 1/10 of it, we're going to pick people. There's a little more granularity there. As chances are, in fact, what really happens is organizations that employ a lot of low-wage people, like, for example, the kitchen at the cafeteria at a hospital, employs a lot of relatively low-wage people. Those people turn over a lot, so you have a lot of recruitment. There's, and no offense to them, but they tend to also get into more trouble, which is part of why they tend to they turn over a lot more, right? So, whereas if you're an ophthalmologist, you can't afford to screw around too much, because if you get into trouble, you could lose your medical license. So there's a much higher cost to getting fired if you're an ophthalmologist than there is if you're a dishwasher, right? Yeah, Caitlin.
Does it matter, like you said, like the kitchen or
So Caitlin asked, does it matter? Because I'm using an example, I'm jumping between profit centers and cost centers. And so, so we're going to look at two methods. We're going to look at two methods that require allocation of costs. One of them looks at strictly allocating. The first one we're going to look at allocates cost centers directly to profit centers. And so it wouldn't matter. We don't look at allocating HR costs to the cafeteria, for example. The second method, that's called the direct method. The second method we'll look at is going to be called the step-down method. And in that case, we actually look at allocating HR costs to, say, finance costs to, say, administration, and then administration costs to the overall organization. So the answer is it depends on which method you're using, but it does matter. And you can think about it kind of both ways, right? So let's say we pick people, we would then say, all right, so our cost driver, if our cost center is HR, right, or our cost pool, excuse me, our cost pool is HR, we would add up all the costs of our HR technicians, our HR software and applications, right? The supplies that they use, right? So if they write physical checks, or whatever they do, all the paperwork that they do, all those things would go into the HR cost pool. Let's say that adds up to $1 million, and we decide, you know what, the driver is the number of people, right? Then the next step is to calculate the allocation rate. Right? And the allocation rate is the cost pool divided by the cost driver. And this cost driver is going to be the total for the organization. So if there's 150 people in the group practice, we're going to use 150. So we'll divide $1 million, in this case, 1 million, by 150 people, $1 million divided by 150 people. And that comes up to, I can't do this in my head, it's going to be a fraction. Is going to be 6,666.67 per person. So the allocation rate within our organization would be, for every person in your clinic, right, we're going to allocate to you $6,666.67. Right? So that would be the allocation rate. Let me back up for a second. So let's talk about cost drivers. If we were talking about housekeeping, so we had done, our initial discussion was housekeeping. What would you use for a cost driver for housekeeping? What makes housekeeping more expensive? What would cause you to have to increase your housekeeping budget? Square footage is a great one, right? So if we expanded our practice from, say, 10,000 square feet to 15,000 square feet, we would probably have to dramatically increase our housekeeping budget. We'd have to hire more housekeepers, we would use more supplies, right? So on. Okay. What else drives what else would be a good housekeeping driver? Well, that would be part of the pool, right? That would be part of our cost. Yeah. So more patients, so more patients coming into our organization, so more volume, right? So you could look at volume of service by, volume of patients by service, because the more people coming through your service would be so you could use number of visits, and say, okay, if you have more patients coming in, then you're going to have more, dirty feet walking through and more trash, and okay, so that's good. Yeah. Number of surgeries, okay. So you could kind of get granular and say, well, what kind of procedures are you doing? Because you could have the same number, so this is a good point, you could have the same number of patients coming through your organization, and if you're coming in, say we had 100 people come through the ER and 100 people come to pediatrics, right? Chances are the ER is going to be messier per person than pediatrics is, right? Because people coming to the ER are bleeding and throwing up and doing, not that pediatrics isn't bleeding and throwing up too, but on average you're going to be more bleeding and more throwing up here than when you're coming into the ED than you are into your outpatient clinic. So probably the most common one is square footage, followed by, you could actually, as a driver, because what you're looking for is a way to divide cost up. So another common one for housekeeping is to say, well, let's just keep a track of how many hours housekeeping takes to clean your space. So now you have an outpatient clinic, relatively clean, runs 8 hours, 10 hours a day, as opposed to the ED that runs 24/7 with bleeding, throwing up patients coming in, right? Even if they have the same square footage, the ED is going to require because it's running 24/7, it's just going to require more manpower, right? And manpower and one of the things to think about is with housekeeping is highly manpower intensive. So, so you're going to require, so manpower is probably going to be the most expensive part of housekeeping. And so if you can keep track of hours, then you're going to want to do, if you can keep track of hours, then you'll probably get a more accurate, if you use hours as a cost driver, then you'll probably get a more accurate allocation rate. And then, and that's probably more fair. What's the downside well, what's the upside of using square footage as opposed to, so we're talking housekeeping, right? Say square footage versus hours. What's the plus of doing square footage? Yeah. It won't change day to day, right? We measure your space and we say, this is how much it's going to cost you. And until we give you more space, this is your bill. So that's really nice, right? It's really simple. We don't have to keep recalculating. What's the challenge of, we already talked about the benefit of hours is it's going to be more accurate. What's the downside of hours? Exactly. You have to, Caitlin said, it's going to change and you're going to have to keep track of it constantly, right? So somebody's some housekeeper supervisor is having to say, okay, Bob spent 4 hours in pediatrics, 2 hours in optometry, and then and each month you get a different housekeeping bill. So that's a challenge. All right. So now step 4, kind of keeping going here. We've identified our cost pool, step 1. We've identified our cost driver, step 2. We've identified our allocation rate, step 3. And now we're going to calculate the allocation amount. And this is the last step. So let's go with our HR example. HR cost was going to be $6,666.67 per person, right? That's our allocation rate. So then we need to know, okay, optometry has 10 people. So optometry's allocation amount is going to be 10 times 666.67, which will be $66,666.67, right? So the amount that goes to optometry for housekeeping, sorry, for HR, not housekeeping, for HR is going to be based on the allocation rate times the number of people. If ophthalmology, I can never spell that right. It's like I don't know. It's a goofy spelling. If they have 3 people, then they're going to be 3 times 666, which is whatever it is. That's 20,000, right? Okay, so that's it. 4 steps. So we're going to stop there for today, and we'll pick up and we'll keep driving with that. We'll get into a little more detail next time. All right, people of Zoom, thank you.
I have a question. I have a question.
Is somebody?
I have a question.
Yes, Deb.
For homework 5,